So for our MEC Minute, we're going to talk about something new for us. It's called delayed sequence intubation. In other words, how we're going to reconsider how we manage patients who need to be intubated, and we're going to reconsider our RSI process. So why are we talking about this? Well, we are talking about and thinking about adding delayed sequence intubation, or DSI, to our 2020 protocol. So this would be a substitution to our current RSI process. It will require additional equipment. Principally, it's going to require that we use a PEEP valve that we can add to our current BVMs. These cost about $5.50 a piece, or we may transition to BVMs that already have a PEEP valve in them. That would be a local call depending on what your department wants to do for purchasing equipment. If we elect to follow this DSI process, then it will also require a significant amount of time and effort in training so that our crews are aware of the process and we're comfortable doing this. I'm also talking about this today because your comments, ideas, and recommendations are important. I think the DSI process is credible. I think it makes sense. I think there's some research behind it, which I'll discuss in a minute. But I would like you to look at it, listen, think about it, and poke holes into what I have to say, because I think it is important to get your input. So I really want to know what you think about the process. I want to know about what you think about training, and importantly, I also want to know what you think about this in terms of your manpower capabilities. So please send your comments to me via this email address, paul.zeeb@violet.oh.us. Please, as part of the topic, or indicate the reason for sending the email so I can start sorting. So what is DSI? DSI is really rearranging what we already do. So what we're talking about today is in line with what we currently do as part of our RSI process, but it's rearranging the order of what we do, and it's adding a new piece of equipment. So if you look at our DSI process, our RSI process now, we already have a component of patient preparation where we're going to pre-oxygenate the patient via nasal cannula or BVM or CPAP. We haven't really emphasized the use of CPAP in our patients who require intubation, but it's really something that we should be considering in patients who are in respiratory difficulty and need an airway to be placed in the field. But if you look at the process, what we're really doing is we're taking this pre-oxygenation phase and kind of putting it in between the administration of ketamine and the administration of our paralytic or succinylcholine. So bear with me, I'll walk you through the process and we'll talk more about it. There should be no doubt in anybody's mind that pre-intubation hypoxia is common and it's harmful. There are studies out there that show that patients with traumatic brain injury, for instance, have significantly worse outcomes if they have any period of hypoxia or any period of hypotension while being treated by EMS in the field. So our patients, when they are critically ill, are very sensitive to hypoxia, and we need to do everything we can to avoid hypoxia. So pre-intubation hypoxia, it's predictable. We know it may happen if we don't do things well. We know what's going to happen if we don't intubate the patient. And it is preventable, which is what I'm going to argue for in a couple of minutes. And we need to work towards stop intubating patients who are hypoxic. We need to get their O2 sats up, if at all possible, before we worry about placing a tube. This is the oxygen desaturation curve. I threw this in there. It's one of two or three graphs I'm going to show you, but I throw this in there because it shows us that in patients who are normal and have normal cardiopulmonary function, their O2 saturation will stay normal for up to 7 or 8 minutes after their ventilations and respirations are stopped. And that's because there's a significant amount of oxygen reserve in the lungs and so on. If you're talking about a moderately ill patient, they're more likely to be a little hypoxic to begin with, and our safety time is down to about 4 to 5 minutes before they really desaturate. If you're talking about a child, or if you're talking about a morbidly obese patient, that oxygen safety curve, our period of safety where we don't need to worry about oxygenating and ventilating the patient, drops to 2 to 3 minutes. So whatever we can do to extend these curves to the right, push these curves to the right, will increase the amount of time we have to safely get the patient intubated. So this discussion was principally started by an article that was published by Dr. Jarvis in Annals of Emergency Medicine in 2018. He also presented this at Eagles this past March. Dr. Jarvis is the medical director for Williamson County, which is the county immediately north of Travis County. Travis County is where Austin is located. So Dr. Jarvis published this study, and it was a pre and post study where he looked at the percentage of patients who required intubation became hypoxic during the course of intubation. And then he put a bundle of care in place, which is what DSI has become, and he looked at the oxygen desaturation rates in that population of patients. So in the patients pre-study, pre-implementation of this bundle of care, there's a 44% chance that they would become hypoxic sometime during the course of their intubation in the field. Whereas once this bundle of care, once the DSI process was implemented, the risk of developing hypoxia during intubation dropped to 3.5%. So that's a significant drop. Another way to look at it, and this is kind of a hint of what's to come in the lecture, is that in their bundle of care process, before they implemented his new process, they would ventilate the patient with an NRB, they would give the patient ketamine and rocuronium, the patient would become apneic, and they would intubate the patient. Post intervention, after they started this bundle of care as part of DSI, they gave ketamine, they pre-oxygenated the patient utilizing a BVM with a PEEP valve and so on. They maintained an O2 saturation over 93% for 3 minutes before they then gave ketamine and intubated the patient. All of this is available via 2 videos, and I would encourage you to watch the videos. As part of my email distribution of this MEC Minute, I will include the links for these videos. The Williamson County DSI video is their homegrown product. It shows a simulation of a patient who is intubated using DSI, and it's an orientation to the checklist that they have in place. It's about 7 or 8 minutes. It's not difficult to watch. The other demonstration is the PEEP valve video. It's actually a cadaver that's had the chest opened, and a physician is showing the effect of using a PEEP valve on a patient. It ventilates the lungs through an endotracheal tube without a PEEP valve, and then with a PEEP valve. And you can see that with a PEEP valve in place, the lungs actually stay inflated for a longer period of time when the patient is not being actively bagged. Or during the expiratory phase of bagging. So I would encourage you to look at both of these and then think about what I have to say in the next couple slides, and then send me your comments. So what are the DSI steps? Well, the first step is just getting the patient prepped. That's in line with what we do. We get our equipment ready. If we anticipate a difficult intubation, we have our alternate methods of intubation available, whether it's having the bougie out, or having a different laryngoscope, or having your iGel ready to go, so that if you can't get the patient tubed, you have the equipment ready there and you don't have to go digging for it. So the first step after they have medications and everything and gear prepared, they pre-treat the patient with ketamine. So they add CO2 monitoring as part of their process. So they add capnography, and they pre-treat the patient with ketamine IV. They give them 2 milligrams IV. They let it wash around a little bit, and then they pre-oxygenate the patient utilizing a BVM with a PEEP valve. They also have nasal cannula in place on the patient, and they have it open to full flow, and they get the patient's O2 saturation over 93% for at least 3 minutes. Once the patient has been prepped and O2 sat's been over 93% for at least 3 minutes, then they will chemically paralyze the patient. They use rocuronium. I've substituted succinylcholine, since succinylcholine is now our paralytic of choice, and they give the succinylcholine if the patient needs it. So if the patient is already apneic and the mandible is loose, and you can easily visualize the cords after they're pre-oxygenated, then you don't necessarily need to use the succinylcholine, but it's there. And then they actively manage the airway, which means endotracheal tube intubation. They get 2 tries, and if the patient isn't successfully intubated, then they're going to go to a rescue device, which for them is the iGel, which is the same as ours. Here is the DSI checklist that they use. It is pretty extensive. They actually have the in-charge medic go through the checklist and mark things off as they go. That's something I'm considering. Again, I'd like to hear your feedback. There is a lot of things to be said about using a checklist. If you notice on the checklist, they also manage hypotension with push dose pressors. That's a whole different discussion. It's something else we're considering as part of the protocol. So whether or not we have push dose pressors in there is yet to be determined. But they do medicate the patient with ketamine. They have the patient on capnography, and they go ahead and get the patient oxygenated and eventually get the patient intubated. So let's go through this on a step-by-step process. So the first thing is positioning. So they position the patient, they get the head up 15 degrees. I know I get the patient up 15 degrees when I intubate the patient. I just feel more comfortable that way. Physically, it's better on my back, but I'm also less concerned about getting the patient or having the patient aspirate. But their idea is to get the patient's head up 15 degrees, get their nose in a sniffing position, and get the earlobe to be in line with the sternal notch. The lower neck is flexed, and the face is more or less parallel to the ceiling. The second step is to give the patient ketamine. So they'll give the patient the ketamine once the patient's dissociated, which is usually 45 to 60 seconds, and dissociated means the patient is now under the effect of the ketamine and the brain is disconnected from the body. They'll start the patient on PEEP at 5 millimeters of mercury, utilizing the PEEP valve that's you can see at the lower right corner. PEEP valves are readily available. We've checked; they are available through Boundtree. They're about $5.50, and you can attach them to the exhaust valve of the BVM. You can use any airway adjuncts as needed. So if the patient needs an oral airway or nasopharyngeal airway, you can do that. Whatever's necessary to help get air back. And we also put a nasal cannula on the patient and turn the cannula up on high flow flush, and that cannula stays on running as fast as you get it to run until the endotracheal tube or the supraglottic device is in place. After that, we're going to, or here's just a kind of idea of what you do with the BVM, with the PEEP valve, patients on capnography. The nasal cannula is at full flush, so you're blowing as much oxygen as you can in through the nose. What you can't see is whether or not there's a nasopharyngeal airway in place or an oral airway in place, but I would use whatever you think you need in order to help move air and oxygen into the hypopharynx so the patient can breathe. I think you should also note that they're using a two-handed thumbs down technique to hold the BVM mask in place. So this is a separate person. So essentially you have one person on the BVM, one person on the face mask, and this is a good seal. If you look at this and you look at how it's running, essentially what we're doing is we're providing PEEP to the patient by way of a BVM with a PEEP valve. So this is no different than using your CPAP mask, and it's just a different way of getting to it. And the upside of doing this is if the patient needs any assistance on their ventilations, you can deliver PEEP while you ventilate the patient, and you don't have to worry about setting up your CPAP equipment because you're going to approach the patient in the same way. So you do this. If the patient needs to be ventilated, you ventilate them. You follow this process, and you keep going until the O2 saturation is better than 93%, at least for 3 minutes. So somebody needs to be watching their watch, or get a stopwatch if you need it. You make sure the O2 saturation probe is on a different extremity than where the blood pressure cuff is, and then you keep watching. So why do we look at 3 minutes? Well, if you do it for 3 minutes, you're going to adequately pre-oxygenate the patient, but more importantly, you're going to provide a full nitrogen washout. So if you look at normally inspired air, so what you are breathing now, the O2 saturation or the O2 concentration is 21%. So 21% of the air that you're breathing is oxygen. The balance of the air is nitrogen. So if you have a patient who's breathing room air before you start your procedure, their lungs are going to contain roughly 85% oxygen, or I'm sorry, 85% nitrogen, 21% oxygen, and there's going to be some carbon dioxide in there. And that carbon dioxide level may build up if the patient's not ventilating well. So if you have this procedure and you're following it, that nitrogen is going to be fully washed out so that there's more oxygen in the lungs ready for absorption as part of the normal circulation through the lungs. So that's why we're going to wait 3 minutes. Give maximum opportunity to wash out the nitrogen, get as much oxygen in the lung as possible. Then we're going to give the patient paralytics. So we're going to squeeze the BVM every 6 seconds after the paralytic is given to help just normal respirations. We're going to wait for the patient to become fully relaxed after the paralytic. Generally with succinylcholine, that takes 45 to 60 seconds. What happens if the O2 saturation drops after we give them the paralytic, even though we got their level up? If it drops, we're not going to try to intubate the patient. We're just going to either continue to ventilate the patient or we're going to place an IG. We're not going to worry or attempt to intubate the patient. We are not going to attempt intubation unless the O2 saturation is over 93% and it stays there. So then we're going to intubate the patient. We're going to use our video laryngoscope, particularly if it's a patient 10 years of age and older. We're not going to intubate or attempt to intubate the patient more than 2 times. If we can't get the patient intubated after 2 reasonable attempts, and again, a reasonable attempt is less than 30 seconds, and we use the BVM between attempts, then we're going to go to the IGL. My suggestion is that you keep the mask available with your setup with the PEEP valve so that if you can't get that tube in on that first attempt, you put the mask back on and you actively ventilate the patient for a minute or 2 to get their O2 saturation back up, particularly if it drops. So let's assume you get that endotracheal tube in. What are you going to do next? Well, we're going to follow our standard process. We're going to sedate the patient with fentanyl and Versed, and we're going to transport them to the hospital after we've got that endotracheal tube in place and secured. So once the patient's airway is secured with an endotracheal tube or with a supraglottic device with an IGL, if you're not successful with the endotracheal tube, we're going to sedate and transport per our routine care. So what do we do if the patient's already apneic or in cardiac arrest? Well, first priority is going to be CPR and defibrillation. So, you walk into the room, the patient's unconscious on the floor, they're in arrest. We're going to do CPR and defibrillate them first. Then we're going to move to our BVM ventilations. We're going to follow our priority-based protocol for resuscitations. So we're going to follow our process of resuscitation, but we're also going to follow our process for trying to get the O2 saturation up. So if at all possible, we're going to use a PEEP valve. We're going to use 2 hands to hold the mask on the face. We're going to ventilate that patient as much as possible using an airway adjunct such as a nasopharyngeal tube or putting a oral airway in place if we need to facilitate ventilations. But the process should not be a whole lot different now. We're going to try to get air into the patient. We're trying to ventilate them and use PEEP if we can. This will take a little bit of practice with our crews in terms of what is our new process for cardiac resuscitation. And then ketamine or succinylcholine may not be needed in these patients if they're already unaware. But you can use ketamine and succinylcholine for these patients if they are having agonal respirations and need an emergent airway. That's going to be your call. I think I would use those meds because I want to get this patient intubated as safely and as comfortably for the patient as possible. So I think it'd be unfair to talk about this process if we don't talk about some of the criticisms of the DSI bundle. So one of the criticism of Dr. Jarvis's article as part of an associated editorial was that this bundle of care that he describes, which is the steps I just went through, there are multiple interventions that indicate there is a better patient outcome, but they were done as a group, so you can't isolate any single intervention or part of the process that was beneficial or potentially harmful to the patient. So I think that is a criticism, but from my perspective, what was the end result? The end result is there was less experience of hypoxia by patients being intubated than after the bundle was started than before the bundle was started. I think there's another criticism. What is the value of DSI when an O2 saturation is normal at the start? Well, I think that's a reasonable thing to say. Why are we putting patients through all of this if their O2 sat is already normal? Well, if you think the patient needs to be intubated, there's always that risk that they're going to develop hypoxia as part of the process. So anything we can do to reduce the risk for hypoxia is to the patient's benefit. particularly if you think about patients who are obese or have significant chronic illness. Your normal patient who is healthy, 70 kilogram person, you might have 6 to 8 minutes to safely get the patient intubated. But what happens if you have an obese patient who maybe has a normal O2 saturation but needs an airway? If you have an obese patient, you only have 2 or 3 minutes. So if you can improve or increase that timeline by following this process, the patient is better off and the patient's more safely intubated. Another criticism is the cost of training and equipment. For me, the cost of equipment is minimal. We already use oxygen cannulas. We already use capnography. We already use a BAVM. So the additional cost of equipment is a $5.50 PEEP valve. That's not a deal breaker to me. But I think it is reasonable to think about the cost of training. If we're talking about rolling out a new process, this is going to take some time and effort, and we all know that training costs dollars. And if you look at it from the perspective of at least Dr. Jarvis's experience, 1/4 of 1% of their patients that they care for require airway interventions such as this or require DSI. So if you have 1/4 of 1% of patients, which basically is 1 out of 400 patients, is going to require DSI, is it worth the cost of training and equipment? So I think that is something to consider. I still think the cost of training and equipment is worthwhile, even for such a small number of patients. Another criticism is longer scene times. I think that is something to consider. But I think, again, if we're talking about doing something safely, we're talking about adding 3 to 5 minutes to a process. I don't see that as a big issue unless you have a patient who has other needs that require them to be transported immediately, such as a major trauma patient. Manpower is also a consideration. So if we're talking about a process that now requires at least 2 people to ventilate the patient and prep the patient for intubation, that may be an issue for some of our departments. But typically, my experience is for our member departments, an ALS response for someone with an airway issue, you have an engine company and a medic on scene, so they should have 4 to 5 people available to assist to work on the patient. I think manpower is a consideration, but I don't think it's an absolute reason that we should not be doing this. And then there are still people involved in pre-hospital care, and some of the authors of the editorial criticizing this bundle are in that population of people who still are not convinced that EMS intubation in the field is of positive benefit to the patient. So the people who wrote the editorial criticizing or finding fault with Dr. Jarvis's article, they tend to be 3 physicians who still doubt the utility of EMS intubating in the field. So in summary, we're talking about transitioning from RSI to DSI. For me, I think it is something we should do. But again, this is the reason I'm talking about it now. I want your input. Our goal is to have the DSI protocol completed by mid-July so that the EMS supervisors and EMS chiefs can give their first review and input on this. We should consider using a DSI checklist if we assume DSI is going to replace RSI. I don't see that as a big deal, although it may be burdensome and we may need to pare it back a bit. And then I think there are also some psychological barriers at play, and I'm probably one of them, or I have my own barriers, and it's really coming down on training us old dogs new tricks. It took us several years for us to be comfortable with RSI. Now we're talking about transitioning to DSI. How comfortable are we in doing this process? So again, I'm interested in hearing your comments. Please send me your comments after you review this video. Also, there are 2 other videos I would encourage you to look at. The Williamson County video gives you a good idea of what the process is like, and it's very straightforward, and you can see how they work it through. And then there's also the PEEP valve video, which shows you the benefits of using a PEEP valve on a patient who's being ventilated. I think it's a minute and a half. It's educational, and I think you'll find it interesting. So again, please send your comments. Thanks again for listening to me.